Happy to have you here again. So you all got up this morning. I'd like to introduce our first speaker, who's Dr. Teresa Stadler-Camden, and she is a very unique lady who is the medical director of Commonwealth Sports Medicine. She's board certified in both sports medicine and family medicine, and she's also a fellow of the American College of Sports Medicine. There are not very many of those, and so that's a distinction. In addition to that, says she is an avid marathoner, an Ironman triathlete, and has a black belt. I'll be very careful not to offend Dr. Cameron.
We're going to be talking about, test 1, 2. Is that better? Too much? Sports medicine, head and shoulders, knees and toes. We're just going to spend a couple of slides talking about head issues. And so when we speak about concussion in the athlete, the American College of Sports Medicine asks you guys, the primary care provider, that you implement these 5 protocols here. And so it's important to train the coaches to recognize the signs and symptoms of concussion. They're pretty good at that. And so more importantly, you guys need to educate the parents and students and get them to sign off on a form, literally, before the very first practice or tryouts happen, that say that they understand the policies and they understand when in doubt, sit them out, and there will be no arguments about that. And so if coach, trainer, or anyone else on the field has a question or there's a doubt, we sit that athlete out. Return to play requires medical okay. Athletes are familiar with hearing that now. That needs to be from a licensed medical provider. Teacher training is also important. These athletes are returning to school, and they need to function at their highest acceptable level. And if that's not being able to concentrate for long periods of time or not being able to be around noise, the teachers need to know how to be able to accommodate that. And so it affects them socially and academically, and it's important for the teachers to know that. What do you guys need to know in the office? When you see the patient, you're going to treat their symptoms. If they're having nausea, you're going to treat their nausea. If they've got difficulty concentrating, you're going to help them treat that. Along those lines, you need to know when you need to get them out of your office. Have a standard protocol. If they're not better at 7 days, get them out, or 30 days, get them out, and send them to the local concussion clinic. If they're having anything vestibular or visual going on, you need to get them out and send them to the local concussion clinic as well. Focal neurologic signs, get them to a specialist. The step-up return is where you guys are going to have an important role to play. Step-up return for the athlete means he's going to start off with mild, not very vigorous cardiovascular exercise, progressing to more vigorous cardiovascular exercise, progressing only then to sports-specific activity, and then to sports-specific play without contact, sports-specific play with contact, finally to games, and then lastly to tournaments. At any point in there, if she has more symptoms, she returns to the previous level. And so we're going to move on and talk about the more sexy parts of sports medicine, which is the musculoskeletal part. And so is anybody going to try to play some golf later on today? Try to do it with a bowling ball? In order to understand the shoulder, moving on to the shoulder, I want you to understand the anatomy of the shoulder. Of course, it's made up of 3 bones. We've got the clavicle here in front, the scapula posteriorly, and the humerus down here. Anybody want to name the muscle that runs through that tunnel right there? So right in that tunnel is where, of course, you have your supraspinatus tendon. And here's what it looks like. Here's the origin, of course, in the supraspinatus fossa and its insertion onto the humeral head. Of course, if you can imagine abducting this arm, the shoulder, the arm, is going to impinge on any kind of structures in this tunnel there. And so there are 3 important structures in that tunnel that will get pinched. You've got the capsule, you've got that supraspinatus muscle that we just looked at, as well as the bursa, and that's important when we look at shoulder pathology. But this is, of course, the view that you're going to see. Of course, you need to know the clavicle is over here, the AC joint's over here. I'm going to move the mic to the other side so I don't lose it every time I turn my head, if you don't mind. Excuse me. And this is the insertion right here of the supraspinatus on the greater tuberosity, and that's usually where these patients end up having some pain. Posteriorly, the spine of the scapular spine, turns at this point right here and heads north and turns into the acromion. The supraspinatus muscle, of course, lives right here in its supraspinatus fossa. We're going to go over a little chart on how to diagnose a shoulder condition simply by knowing the age and the gender of the patient. This isn't published anywhere. This is simply something I've come up with 10 or 15 years ago, and I've taught it to multiple residents and students and other physicians. It's pretty accurate. So before you even walk in the room and talk to the patient, just knowing the patient's name and gender, you're able to come up with a pretty good differential diagnosis. And so this is what the full chart looks like. We're going to go over each one of these items one at a time, starting out with young gentlemen who are having traumatic injuries. So traumatic injuries of the shoulder, of course, can result in a dislocation. And this is how you're going to see it in the office. The point of the acromion is here and the humeral head is sitting down here. This age group has traumatic dislocations. The eponym for that not the eponym, I'm sorry, the acronym for that, of course, is TUBS. And that's what you need to remember about these issues. These are traumatic, they're unidirectional, and unilateral. They happen on one side only, of course. They can result in a Bankart lesion, which is a tear of the labrum of the glenoid fossa. The glenoid fossa is surrounded by the glenoid labrum, which can tear as the shoulder dislocates. These are frequently surgical problems, and so if you're not comfortable treating them, these are okay to get out of your office and send off to the surgeon. That's what it looks like. This is my favorite way to reduce it, on the sidelines or quickly after the injury. If you don't get it back in place in one attempt, get it out of your office and get it to the emergency room to reduce it. But if you simply put them through gentle external rotation, you can frequently reduce these easily on the sidelines. If it's been more than an hour, or certainly if it's been several days, these are not going to go in easily. These patients are going to need to be sedated in order to reduce that shoulder. What other types of dislocations can these athletes get? They can get acromioclavicular dislocations. And so here's the clavicle. The acromion, of course, is sitting down here, and the clavicle is sitting superiorly. That's what the acromioclavicular dislocation looks like in the office. That's what it looks like on plain film, with or without weights. It really doesn't matter. And that's your treatment for it. You can treat these in the office. These almost always heal without surgical intervention if you can just get them in a sling for a few weeks, followed by vigorous rehabilitation. We're going to move over to the other side of the chart here and talk about the young female athlete. She's going to sublux her shoulder. She's not going to dislocate it. And it's going to be an atraumatic injury, and it can go out in just about any direction. So rather than a complete 100% dislocation, she's dislocating less than 50%, and then the joint goes right back in where it was before that. This is bilateral, and these get better with rehab. Treatment for this is to rehab the heck out of it. Here's my favorite physical exam finding for this. Does anybody know the name of that? That's a sulcus sign. And so from standing behind the athlete, if you can get your fingers on the clavicle and your thumb on the scapular spine and pull the humeral head down, you'll see a sulcus right here. And so that's the sulcus sign, where the humeral head is pulling inferiorly and leaving that divot there. Treatment for this is to rehab the heck out of them. If you strengthen all of the muscles that go from the scapula to the humerus, which is, of course, the rotator cuff, you can hold that shoulder in place much more efficiently. Keeping them away from the surgeon is a good idea. I consider it my job to keep these patients away from the surgeon. If they do go to the surgeon, they may end up with a surgery more quickly than they should have. The surgical procedure is a capsular shift, in which the capsule is opened up, take those two free edges, overlap them, and sew them back down again. And so that's what the capsular shift looks like on the inside, sewing those free edges back over. It frequently, almost always, results in a shoulder that's too tight, and then she spends the next several years trying to loosen up that shoulder again. Let's talk about the slightly older age group of these still very young people, of the 20 to 50-year-old athlete here. They might get acromioclavicular osteoarthritis. It's a post-traumatic condition, and when I teach the students and residents about this, I say this is the typical 30 to 40-year-old guy, 30-something or 40-something, who comes in with a big barrel chest. He looks like he's been doing too many chest presses his entire life. And so he's been lifting weights and going too hard with the chest presses. And so this guy was very proud of the fact that he can balance a glass of water right there. And so these patients are ending up with post-traumatic acromioclavicular osteoarthritis. Treatment for that is like any other osteoarthritis. Stabilize the two joints so they don't wiggle around on each other so much. Decrease the movement at that joint with vigorous rehabilitation. We're going to get back to this picture that we just talked about here. If you remember, we talked about abducting that humeral head. Abduct the humerus, impinges on these three important structures here. And so this age group is ending up with subacromial impingement. The favorite test for this is the empty can test. And here's how you do it. If you get the athlete to abduct, 30 degrees of forward flexion, internal rotation, thumbs down, tell her to push up against you. This produces pain. There's no weakness with this test, but there's pain. You treat this like any other itis type of problem, so we can anti-inflammatorize them orally, topically, if necessarily, injectably, and then rehab them in order to strengthen the muscles that will pull the humeral head south. Here's how you do the injection. If you guys can just palpate the shoulder of the guy next to you. You don't have anybody next to you on this side, so figure out somebody to palpate. If you palpate along the scapular spine, no, literally touch the guy next to you, I'm sorry. Palpate along the scapular spine. Find the point where that scapular spine turns to head anteriorly. From that point, if you drop your finger 1 centimeter inferior and 1 centimeter medially, so from this point, go a centimeter inferior and a centimeter medially, everybody's got a divot right there. From that divot, you put the needle right through the skin, quickly through the skin, of course, because that's the part that hurts. If you aim the needle up towards the chin, you're in the subacromial space. If you aim the needle down towards the ipsilateral needle, you're in the true joint space, in case you want to do a true joint space injection, as in for glenohumeral osteoarthritis. But that's the simple way to do these. You'll never hit bone if you do that correctly. If you hit bone, stop, because that hurts. Periosteum is very well innervated. What does the next older age group get here? Those guys don't get impinged anymore because their tendons are no longer spongy and able to crush, but rather they tear. These folks end up with a rotator cuff tear. Favorite test for that is the empty can with weakness. So the same test, abducted, 30 degrees forward flexion, internal rotation. They don't just have pain with this, but they have severe weakness with this. They're unable to do that test. Late referral. Keep these guys in your office. Keep them away from their surgeon. The surgeon sends them immediately for a rotator cuff repair, and there's no evidence that that does any better over time. Rehab the heck out of them first. And so in a big study to determine the effectiveness for rotator cuff disease, these authors looked at 14 randomized controlled studies of almost 830 participants and concluded that we cannot draw firm conclusions about the effectiveness of or safety for surgery for rotator cuff disease. They do not necessarily do better in the long run if they end up with surgery. It's simple, so keep this patient away from surgery as well. My nurse blindfolds me, I spin around and reattach your tail. The next older age group looks like this. She's the hypothyroid-looking, slightly heavy, long, dry face, long, dry hair and skin who gets frozen shoulder. There's some components of autoimmune disease to frozen shoulder. And with frozen shoulder, what you need to know in order to make the diagnosis is the first thing to go and the last thing to come back is internal rotation. That's important to remember. The first thing that leaves the patient, the last thing they get back is internal rotation. She's unable to internally rotate that arm. The best way to measure that on your physical exam is her ability to reach up behind her back. And so she's had to switch to wearing a front closure bra because she can't reach behind her back anymore. And the best way to measure that is ask her to reach up behind her back with her good side as far up as she can. Measure that. She can get about to her inferior scapular pole. With the affected arm, she may only get to her lumbar spine. She may not only even be able to get to her gluteals or her sacrum. And that's the way to report that. Treatment for this is to stretch the heck out of them. Frozen shoulder is adhesive capsulitis. The capsule itself has become stiff. The treatment is to stretch the heck out of it. Just doing the stretches once or twice a day does not cut it. I'll tell these patients, whenever you're sitting still, you're going to elevate your elbow. Prop that up on a bunch of books over there to stretch the heck out of that. Whenever you're walking around, you're going to hold your hands behind your back, holding the hands behind the back to increase internal rotation. These guys need to be stretched out all day long, and they do get better. But in the best possible hands, in the best case scenario, the best stretching program, they take 6 to 12 months to get there. Next older age group ends up with true glenohumeral osteoarthritis. True shoulder joint arthritis is not a common condition. It's fairly uncommon. It happens almost exclusively in gentlemen just because women were not doing the types of things that dislocated their shoulder 50 years ago, specifically contact sports. It's almost always post-traumatic. The diagnosis of it, if you palpate the shoulder while you abduct it, it's got a very low-pitched crepitus, and it stops frequently in there as it catches. It's a low-pitched crepitus, not the high-pitched kind of cracking your finger knuckles crepitus. What do you do about it? You treat them like any other form of osteoarthritis. Get them stronger. Get them on a good weight management program. Tylenol if necessary. Intra-articular steroids if necessary. Hyaluronic acid not indicated for this problem, but very effective for that as well. Treat it like osteoarthritis. We're going to move down and talk about the next joint that we're going to go on to today, which is the knee joint. And so I wanted to know if this guy's missing his knee is a serious problem. We're going to talk about the knee pain from 4 different sides of the knee, starting out with pain on the lateral side of the knee. Pain on the lateral side of the knee in an athlete is almost always iliotibial band friction syndrome. And so this athlete is hurting right over here where this iliotibial band rubs across this lateral femoral condyle, or she's hurting down here where the iliotibial band inserts onto Gertie's tubercle. And so palpation in those 2 spots is very helpful to make this diagnosis. What do we do about it? I want you to appreciate the anatomy in order to understand what we do about it. And so you got your femur up top and your tibia down below. From the ilium to the tibia is, of course, the iliotibial band. I want you to imagine every time she takes a step, that knee joint is moving back and forth in and out of the screen. As it does that, it's rubbing back and forth over that soft tissue there. And so you've got bone rubbing against soft tissue. Everywhere where bone rubs against soft tissue, of course, builds up a lot of friction. And so there's a friction absorber right here called the bursa. That bursa gets red and angry and inflamed. And then you've got iliotibial band friction syndrome or iliotibial band bursitis or just ITBS if you're cool. So that's what's going on there. This is an itis condition. It's a true inflammatory condition. And so anti-inflammatory is very effective there. We're also going to put these athletes on a strap right across that area to physically, mechanically hold that band in place so it's not snapping back and forth so hard across that lateral femoral condyle. Physical therapy to strengthen the abductors and the adductors to keep that band from snapping back and forth so much, as well as varying the pace of the activity. And so if this athlete hurts every time she runs, tell her to never run her usual pace. Rather run 2 minutes slightly faster than usual, followed by 2 minutes slightly slower than usual. And there's good evidence that simply varying that pace, changing that pace up, changes the angle through which the knee joint moves on the recovery phase of gait, which will change the way in which that band snaps back and forth across that condyle. We're going to go to the other side of the knee. And so analogous condition to iliotibial band friction syndrome on the other side of the knee. Think about if you know what that condition is called. The other side of the knee, of course, ends up with Pes bursitis. So the medial side of the knee has an analogous structure. We've got the Pes tendon here, the conjoined tendon of three other muscles that comes down and joins right here and inserts on the medial aspect of the knee. Similar pathology. Every time we take a step, of course, the knee joint moves in and out of the screen and rubs against this soft tissue structure here, building up friction. The bursa is the friction absorber there that gets red and angry and inflamed. And then we've got Pes bursitis. Treatment for this, similarly, we're now putting the strap and the buttress of the strap medial and inferior to the knee. So this is the medial side of the knee right now. And we're putting that buttress right across that area there to mechanically hold that tendon in place so it's not snapping back and forth so much across that medial tibial plateau. These patients are tender right over here. We're also going to get them into physical therapy to strengthen their adductors here and anti-inflammatorize them orally, topically, and injectably. How do we do this type of injection? I always get that question, even though it's kind of beyond the scope of the slide here. So just like the shoulder joint, we've got a picture here of how we do this injection. Here's the medial side of the knee. Here's where this patient is tender to palpation with her Pes bursitis. Here's where this patient may be tender with iliotibial band friction syndrome. You're going to put the needle right in where the patient's hurting, perpendicular to the skin, quickly through the skin, of course, because that's where she's hurting. You're going to inject, peppering out over an entire area of about 2 square centimeters, a concoction of 1 or 2 cc's of your favorite steroid and 1 or 2 cc's of lidocaine, and spread it out over that whole area, tapping bone, pulling back, and injecting around that area. The name of this angle here, think about what if you know the name of the angle, formed between these 2 lines. And so it's the line from the greater trochanter to the middle of the patella to the tibial tubercle, intersected with the vertical line here. Here it is on a gentleman, here it is on a woman. And so that's the Q angle, or the quadricep angle. In a gentleman, we like to see it less than 15 degrees. In ladies, we like to see it less than 20 degrees. If it's more than 20 degrees, she's at risk of patellofemoral problems and of ACL tears. And so I want you to think about what puts her into that position. And so anterior knee pain caused by this position and what gets her into that position is usually a postural core strength issue. While you're sitting there, I want you to imagine getting into this anterior pelvic tilt poor posture position by relaxing your lower abs. First contract your lower abs and then relax them. As you relax your lower abs, I want you to feel how your spine goes into a lordotic sway back arched position. With your spine in an arched position, you're in this anterior pelvic tilt. This anterior pelvic tilt results in internal femoral rotation. I'm going to do this, but it's not pretty. As the femurs internally rotate, I'm forced to fall into this knock-kneed, run-like-a-girl position with my femurs internally rotated into a knock-kneed position here. This puts me into this compromised knee adduction, knock-kneed position, which now allows my patella to no longer live in the middle of its groove, but rather to rub along the side walls of that groove. So all because of my weak core, my patellas are now rubbing along the side wall of my patellar groove here, causing chondromalacia. So anterior knee pain, otherwise known as patellofemoral syndrome, patellofemoral chondromalacia, so bad kneecap cartilage, also known as just PFS if you're cool. What do we do about this? You treat the core, treat the strength of the lower abs and the hips much more than the traditional approach of treating the quadriceps and strengthening the quadriceps. And so if you're going to teach one simple exercise in your office before you send her off to physical therapy, use this one, which is clamshells. So you can do this simply on your table and have the athlete lie on your side, relax your head on your bent elbow there, keeping the pelvis in a neutral position. You're going to tell them to keep their toes together, keep your feet together, and lift your knee up and touch my hand. Hold it there and slowly back down. Lift your knee up and hold and slowly down. So now we're strengthening the external rotators of the hip. Strengthening those external rotators is going to keep the knee out of that adducted knock-kneed position. What else are we going to do about this? We're going to try to mechanically hold that kneecap in place. And so we can do this with a simple, cheap 2-strap brace. We can do it with a much fancier brace. My favorite brace for this is a surf strap. Surf stands for stability through external rotation of the femur. The Don Joy surf strap, I have no relationship with them, externally rotates the femur to hold it in place. And so here you can see this athlete doing this step down test without and with the surf strap on. I want you to appreciate how this strap is externally rotating this femur to keep her knee out of that knock-kneed position. And so with the brace on, she does not fall into that knock-kneed position. What else are we going to do about this? The knee is the culprit, and the hip and the knee is the victim. The culprit is the hip up above and the foot down below. And so we've talked about addressing the hip. We're going to talk about addressing the foot as well. And so if you can imagine, a pronated foot is going to put that knee into a more knock-kneed position. If we just fix that pronated position and get her into a neutral position here, we can get the knee out of the knock-kneed adducted position. What else are we going to do about this? You're going to treat it like osteoarthritis, so anti-inflammatories if necessary. Hyaluronic acid injected right into that patellofemoral joint is also very effective. Let's talk about pain on the back side of the knee. In order to understand pain on the back side of the knee, I want you to understand a little bit more about the anatomy of the knee. And so you got your femur up above and your tibia down below. Here everyone has a medial meniscus and a lateral meniscus, or two menisci. These menisci are meant to handle, it can handle just fine, any kind of up and down pounding. What they cannot handle is any kind of twisting on a planted foot. And with twisting on a planted foot, the meniscus likes to tear posteriorly. This meniscus almost always tears on the posterior side. And so here's what it looks like on the inside. And with a tear back there, you can imagine the patient's going to have pain on the posterior aspect of the knee. And so if you bring that knee way up into a flexed position and push it even more, pain on forced flexion is a good sign for a medial meniscus tear. Or you can try to do a fancy, difficult to perform, not sensitive, not effective McMurray's test, but this is how that's done. But pain on forced flexion is a very good test. The other test that you need to know, and we'll go over this on my next talk today, is a Thessaly test, which is pain on standing rotation of that knee. And so just know that the McMurray's test is not sensitive or specific. We're going to rehab the heck out of these patients in the office and in physical therapy with a bunch of very simple exercises. And so that's how that looks. Why did the golfer wear 2 pairs of pants? So we're going to move on and talk about the toe. We've done head and shoulders and knees, and now we're going to talk about the toe with respect to this case here, who's a young lady who comes to you with pain with running, pain in her narrow dress shoes, and pain on long standing. She's better when she rests it. She's better when she takes pressure off of her feet and goes barefoot. She's treated this with everything, which in my office usually means she's tried some Tylenol and some ice, and so ibuprofen and ice clinic, I&I clinic, ice and ibuprofen. If diagnosis is made on history alone, you should have some idea what her differential is from this, but let's go on and review a formal differential diagnosis of this. So she may have pathology of the bones, which could be a turf toe, a plantar plate tear. She can have something going on with her sesamoid, specifically sesamoiditis or sesamoid stress fracture or sesamoid stress reaction. A Freiberg infarction is an avascular necrosis of the second metatarsal head. Uncommon condition, but that's where she's hurting, and so something to consider in there. Of course, all the different avascular necroses have different eponyms given to them. Does anybody know an eponym for an avascular necrosis somewhere else? And so avascular necrosis of the femoral head, you may have heard, is Legg-Calvé-Perthes disease. When it happens in the lunate of the wrist, it's called Kienbach's disease. When it happens in the capitate of the humerus, it's called Panner's disease. So there's a whole bunch of them. There's a list of 50 or more. The base of the fifth metatarsal is Iceland's disease. It's just a fun list to know. And so Freiberg's infarction, avascular necrosis of the head of the second metatarsal. What else can this be? We've got to include infection on that list. Osteoarthritis of the first MTP joint is hallux rigidus. It's a post-traumatic arthritis, very common in runners. Post-traumatic arthritis from pushing off and hyperflexing that joint with every step of running. What else can be going on? Can she have a tendon issue, a tendinosis, a tenosynovitis, a tendon tear, or even a ligament tear? What else can she have? Soft tissue masses, ganglion bursa, Morton's neuroma, and capsulitis of the soft tissue, or something bad like a neoplasm there, but that's a pretty thorough differential diagnosis for foot pain around the metatarsal heads. And so physical exam of any joint is going to go in this order. In sports medicine, it's nice to always have a normal contralateral side. Rather than memorize this order, think about the order of do no harm. So the first thing you're going to do is just look at your patient. So inspection's not going to hurt anybody. Move on to palpation. You touch the patient and then let the patient move herself. Then you resist her motion, which is, of course, strength testing. Then you're going to resist her motion in non-normal directions, which is stability testing. And then you can move on to perform this special test that we all like to jump right into, like an anterior drawer sign, which may be pretty useless. And so let's move on and do this one at a time. So on inspection, we're going to look for any obvious deformity, erythema, ecchymosis. She may have a black toenail if she's been a distance runner for a long time. This subungual hematoma is almost always asymptomatic. If it hurts her, you can stick an 18-gauge needle in it and drain it, and it immediately relieves the pain. If it doesn't hurt her, I tell her to treat it by putting bright red toenail polish over it and just leave it there. On palpation, she may be hurting over the MTP joint, or she may be hurting over the second or third web space. And so palpate the metatarsals and the web spaces equally. Range of motion of the foot is pretty simple. At the toes, you've got flexion, extension, abduction, and adduction. Strength testing is pretty simple of a toe if you want to do that. Stability testing is for these collateral ligaments here, which can tear on a toe or a finger, of course, and so you can stability test them medially and laterally. More importantly, this exam is a special test, which is this Mulder's test. To do an effective Mulder's test, you're going to put medial lateral compression across the foot with one hand, and with your other thumb, you're going to palpate the spot that hurts. A positive test is a click and pain at that spot. So click and pain at that spot is a positive Mulder's test, and it's pretty pathognomonic for a Morton's neuroma. And so this patient, of course, has a Morton's neuroma. In order to understand that, I want you to understand the anatomy of the foot. So between these metatarsals, of course, we've got these intermetatarsal nerves. These intermetatarsal nerves get to the level of the MTP joint and split and go halfway to each toe. I want you to imagine that every time this foot takes a step, these metatarsals splay back and forth. As they splay back and forth, they come back together again and they rub against that nerve. That repetitive rubbing causes a piece of scar tissue to grow on that nerve. Some dude named Morton put his name on it 200 years ago, and it's called a Morton's neuroma. What do we do about this? We try to stop that splaying, stop those metatarsals from moving back together so much by increasing the short arch of the foot, by putting a pad right underneath the metatarsal heads here. I've almost never had a patient who can tolerate that. It feels like you're running with a bunch of coins in your foot, but if you can tolerate that, it does effectively keep the metatarsal heads from coming back together. I'm pretty quick to inject these because it's very effective and it lasts for several years. And so the needle goes right between the metatarsal heads, to the plantar side of the foot. Don't inject on the dorsum of the foot because the nerve is actually on the plantar side of the foot. So the needle goes in fairly deeply, almost to the point where you feel like you're coming out of the other side of the foot, and put a half a cc of your favorite steroid and a half a cc of lidocaine right in between those metatarsal heads. It's very effective. And so we've talked about head and shoulders, knees and toes. We're ahead of schedule, which I don't know if that's been happening on this conference time here. Does anybody know where that is? It's not Kiowa. That's in Bermuda, and there's Kiowa there. Do I have time for questions, Dr. Piziak? Yes. I do have time for questions. Lovely.
Thank you. Adhesive capsulitis, you
Yes.
inject those patients first before they do rehab?
I do inject those patients first before I do rehab. That injection needs to go into the capsule, not into the subacromial space. And so we were talking about, is there a woman with a tank top on here? Yes, come on up. Can you come here if you would, please? And so we talked about injecting towards the capsule versus into the subacromial space. What's your name, ma'am?
Jean.
Jean? Jean or Jane?
Jean.
Jean. And so from here, you're going to feel her scapular spine, find the point where it turns to head anteriorly and turns into the acromion. From that space, like we said, if you go a little bit inferior and a little bit medially, from here, if you aim towards the ipsilateral needle, you can be into the joint there. There's some thought that it's not just the anti-inflammatory, but the volume effect into the capsule that increases the range of motion here. And so if you can force 12 or 15 cc's of lidocaine and saline into that capsule, you can make it move a little bit better. The surgeon will sometimes even put 20 cc's into there. I'm afraid of rupturing something by putting too much in there. I do these under ultrasound guidance just because I have an ultrasound, but that doesn't help this one bit. It doesn't really make a difference. And so if you can force 12 cc's, half lidocaine, half saline right into that capsule and get it to expand, that's great. 1 or 2 cc's of your favorite steroid does make a difference in this because it will help calm down this scar tissue that's starting to form around those adhesions. Good question. Thank you.
Any common side effects of that procedure? I haven't seen any side effects in the office.
Common adverse effects or side effects. The side effect is that they're numb for the next 2 hours. I tell them to take advantage of that being numb during those 2 hours. We want them to force the heck out of the motion there. Sometimes I'll even scare them a little bit, if you would, please, into just let them know that if this doesn't work in 6 months from now, the surgeon's going to put you to sleep and under anesthesia crank that arm into abduction. It's such a painful procedure that the patient needs to be admitted for several days just for pain management on a PCA pump. But if you can force these people to do these exercises effectively, they're generally the less motivated person. I hate to put them into a box, but you saw it's the hypothyroid person who doesn't want to move, doesn't want to push herself too much. But the common side effect is it's numb there, and if you can tell them to take advantage of that numb period and stretch the heck out of it while it's numb, they can make a little bit of progress. I have the benefit of having a physical therapist stand this close to me all day long, so inject them to have the physical therapist take them into the other room and stretch them for 2 hours while it's numb. Yeah. Yes, sir, in the red. Sure. So PRP and stem cell injection, I do an awful lot of PRP. I was probably one of the first people in my city and even my state to do a lot of PRP injections. We're going to talk about it a little bit with my next talk with respect to treating lateral epicondylitis. I use quite a bit of PRP into lateral epicondyles, Achilles, plantar fascias. I don't use a whole lot of stem cells with them, but I'll frequently put stem cells into the final of 3 to 5 injections in a series of PRP injections. PRP into knee osteoarthritis with stem cell is extremely effective. Where PRP is mostly used and found to be efficacious, though, is lateral epicondylitis. Very effective there. PRP with stem cell, not studied in the knee joint, but in my personal experience, a level of evidence C or D, very effective for knee osteoarthritis. Combine it in the same syringe with PRP. Oh, I'm sorry. There's various ways to get stem cells. I use amniotic fluid, so it's ordered from a company. There's several ways to get it. You can do a lipograft of stem cells from the same patient, or you can do bone marrow stem cell, or you can order it from somebody else. And so I'm using amniotic fluid. Yes. Question over here. Yes, ma'am.
I have 2 questions.
Yes.
How exactly do you do the Mulder's test?
And so maybe after this I can sit somebody down and get just a few people around to show you how to do it. But from this slide, maybe I can show you a better picture of it. So the question on how to do a Mulder's test to look at diagnosis of Morton's neuroma. So I'm squeezing the sides of the foot with one hand, palpating the tender area with another hand. You can actually feel the painful click in there, and the patient winces with a horrible sensation of pain. If anyone's ever had a Morton's neuroma, you know how horribly painful it is, and the pain in that area shoots down towards the toes. And so there's a painful click. So you're going to feel the click, and the patient's going to feel the pain.
So you can feel from above and below.
Correct. Oh, I'm sorry. This hand is feeling from, this pointer's not working. Let me use the other pointer. I think I gave up on the other pointer. Here we go. This hand is feeling from above and below on the second web space, while the other hand, this hand is squeezing the sides of the foot together. This hand will feel a click there.
My other question was, do you what's your information or maybe commentary on partial knee replacements?
So partial knee replacements are very effective, and I like them for the younger 40-something, 50-something-year-old athlete. I've got many very motivated patients who get back to, this is of course all anecdotal, and so level of evidence C here, low level of evidence. My athletes get back to a very high level of play after a partial knee replacement. And so very good procedure in a 40-something or a 50-something. I'd much rather have them do that, knowing full well that they're going to have another surgery 5 to 10 years down the road, but I'd hate to take a 50-year-old knee and cut off the entire thing and replace it with metal and plastic.
So what exactly is the partial versus the total?
So partial versus total knee replacement. A partial knee replacement the partial knee replacement removes everything I'm circling here. So I'm removing this medial femoral condyle. I'm not a surgeon, by the way, but the partial knee replacement removes the medial femoral condyle and the medial tibial plateau and attaches the metal and plastic pieces to that rather than remove everything I'm circling here. So a partial knee replacement, it's almost always medial. It can be done laterally as well, but as you know, 90% of knee osteoarthritis affects the medial compartment first. And so replacing just the medial femoral condyle and the medial tibial plateau. An analogous procedure is a patellofemoral replacement, which just removes the front of the femur and the entire patella. And so patellofemoral replacements are also very effective, and I built my entire practice by keeping patients away from surgery. However, patellofemoral replacements are a very effective, good surgery for an athlete who's trying to avoid a total knee replacement. And so I'm the last person to send the patient for surgery, but both of those are excellent procedures for a 40-something or 50-something, and you'd like to avoid a full knee replacement on them. Yes, ma'am. Yes, ma'am, in the back. So plantar fasciitis, I don't think any of my talks this week are going over plantar fasciitis. I've actually reviewed all of the evidence on plantar fasciitis, and the most effective thing is going to be to strengthen the muscles that are doing the job that the burned out plantar fascia is no longer doing. And so the most important part of plantar fasciitis is not stretching the heck out of their plantar fascia, like most of us have directed our treatment towards, but rather strengthening the muscles to do the same job that the burned out plantar fascia is no longer doing. And so from having the patient in a sitting position first and then progressing them to doing these in a standing position, showing them exercises, the name of the exercise you want to look up is called short foot. And so short foot exercises, it's difficult to do. Most of these patients don't even have the neuromuscular connections to do this exercise effectively. But if you can get them to strengthen the 7 layers of the muscles of the feet, remember your anatomy, there's 7 layers of muscles in there. Most of us never use any of those layers. And so if we can effectively strengthen those layers to do the job that the burned out plantar fascia is supposed to do, we can effectively keep them away from the surgeon. I'm pretty quick to inject these, not with steroid, because of course adverse effects of injecting into the plantar fat pad. You don't want to inject into the plantar fat pad because then you have atrophy and you have a miserable patient. You can also inject too much into the plantar fascia and result in a rupture, but I'm quick to inject these with prolotherapy and or PRP. But for your practice, you need to know to strengthen the muscles to do the job that the plantar fascia is no longer doing. Yes, sir? So meniscus repair, if it's truly repairable, it should be done sooner rather than later because we're looking at a blood flow issue. And so there's two ways that the surgeon can operate on a meniscus. He can either repair it and sew it back together, or resect the torn tissue. A meniscus repair is what's shown in this picture here, and of course in order to be effective it needs it to be in the peripheral, the tear needs to be in the peripheral 1/3 of that meniscus. And so if we're truly looking at a meniscus repair, doing that sooner rather than later is going to have a better outcome. If it's not repairable, or if the patient's over age, whatever you're going to consider an age too old to be repaired, in my mind that's now 50-something because I am in my upper 40s, but it used to be, you know, in a knee more than age 40, we don't repair them anymore, we just resect it because we're not worried about the 20-year effects there. But certainly if you're looking to repair rather than resect, sooner rather than later. You look like it was a personal issue, sir. So if it's a personal issue, I'm just going to assume that you're more than 40 and the repair might not matter. So I'd rather try to rehab the heck out of that first and see if we can stabilize your joint to avoid too much pivoting at that joint in order to keep you away from the surgeon altogether. Sorry if you're a surgeon, if there's any surgeons in the room. Nothing personal. Other questions? Yes, ma'am. So tendinitis is, of course, an inflammatory problem. It's almost never an itis issue. It's almost always an osis issue. And so let's take it in the elbow, for example. It's almost always a lateral epicondylosis, which is too hard to say, and so nobody calls it that, and nobody can really say plantar fasciosis, and so we call it an itis, which it never really is. And so this tissue no longer has good blood flow. It's not an inflammatory problem, and I'm going to show you the level of evidence in my next talk to show that treating lateral epicondylitis with anti-inflammatories gets you absolutely nowhere. And so this is an osis issue. We need to get blood flow to this area. How do we get blood flow to an area? We're going to get blood flow to the area, number one, by keeping it warm. And so there's no role for ice in the treatment of a tendinosis. And so keep it warm. I tell my athlete to keep it almost sweaty, gross, hot all the time. And so I'll give, in the office, give them a neoprene sleeve or a neoprene device to put over the affected area to keep it sweaty, gross, hot, vasodilated all the time. How else do we get blood flow to the area? We can get blood flow to that area by keeping it vasodilated with topical nitroglycerin. And so in my next talk later on today, I'll show you that the level of evidence for nitroglycerin onto an epicondylosis is actually very effective. The way to do that is have them get you just order for them the smallest dose of a topical nitro patch. The smallest dose of the nitro patch is a 0.1 milligram dose. Have them cut into 1/4, put 1/4 of that patch right over that area. So right over the lateral epicondyle, right over the medial aspect of the calcaneal tuberosity with plantar fasciitis, right over the insertion of the Achilles in an Achilles tendinosis, and so effectively keeps the area vasodilated. How else do we get blood flow to the area? We can get blood flow to the area by irritating it to make it bleed, and so that's where prolotherapy comes in, and I do that with dextrose and saline in the office. We can also get blood flow to the area by physically putting the blood there, and so you can do an autologous whole blood injection, which is kind of a no-brainer. You guys can do that in your office without any kind of fancy equipment. So do the phlebotomy, inject that same amount of blood into the area, or we can do it by spinning it down and just taking the platelet-rich plasma, which is what I do, and inject that right into that area. Other ways to get blood to the area, of course, with deeper vasodilation with ultrasound and or massage therapy. So tendinitis, not really an itis, almost always an osis is the summary of that. Other questions? I'm going to stick around and have some coffee and let you guys come up to me and shout out some more questions if you want. I don't know if Dr. Piesiak, if you want to take over this, I'll decide where to go.
Okay, we're going to talk about some new injectables this morning. Insulin's partly. I don't know if you've noticed lately, how many of you use insulin in your practice? Oh, good. Virtually all of you. And it turns out that there's a welter of new insulins lately, isn't there? There are also a welter of new delivery devices. So we'll take a quick look. We're going to take a look at therapy of type 1 and type 2 with insulin, because it's very different. And we'll take a look quickly at some other injectables and also a few cases. And there are some changes in the ADA DA guidelines for both insulin and metformin.